After discussing metronidazole, we go on to discuss what's tinidazole. Tinidazole has got longer duration of action. The metallic taste, which is very significant with metronidazole, is comparatively less, and it's used in the dose of 500 milligrams just 2 times a day for 3 to 5 days. So I hope you notice the frequency of administration is decreasing, the duration of treatment is also decreasing. It's used in single dose, that's 2 grams, in the management of trichomoniasis and giardiasis, and this is supposed to be a better alternative to metronidazole. Secondidazole and ornidazole are the newer derivatives, newer imidazoles, and they are useful in 2 gram single dose in many of the infestations because they have got a still longer duration of action, still longer half-life. Next we go on to consider the management of amebiasis. Amebiasis is caused by Entamoeba histolytica, and you know the cysts are ingested following the contamination of water or food. So the infecting substance which goes inside is the cyst. They remain in the intestines and the cysts are not producing any disease. The patient remains asymptomatic. The cysts become active when they get converted into trophozoites, and the trophozoites start invading the colonic wall and leads to the manifestations of intestinal amebiasis. The trophozoites can also go to the bloodstream, they can go to the liver, and they start producing hepatic amoebiasis, or classically they can produce amoebic liver abscess. The cysts transmit infection from person to person, but the person remains asymptomatic. So if you are carrying the cysts within your intestinal lumen, then the person is called asymptomatic carrier, or this stage is called as asymptomatic carrier stage. Amebiasis is treated by various strategies. Let's have a look at the drugs. The tissue amebiacides, they act on the amoeba present in the intestinal wall and liver. Examples is metronidazole, tinidazole, and emetic. Both metronidazole as well as emetic act on intestinal wall as well as liver. There is one more drug called chloroquine, which is an antimalarial agent which acts only on the liver and doesn't have an effect on the amoeba in the intestinal wall. So tissue amebiacides, those who act on intestinal wall and liver, is metronidazole and emetic, and the drug acting only on the liver is chloroquine. Coming to the luminal amebiacides, who are able to inhibit the cyst in the lumen, that is dialloxanate furoate, iodoquinol, paromomycin, and tetracyclines. So these can affect only the cysts in the intestinal lumen. Have a look at this table. Look at the slide. The first column is intestinal wall or liver. If the drug inhibits this, it's called mixed amebicide. So you have metronidazole, tinidazole, and for severe illness, you have dihydroemetic or emetic. The second column, only liver, is chloroquine, and the luminal is dialloxanate, diiodohydroxyquine, that's iodoquinol, tetracyclines, and paromomycin. I hope it's quite clear. Liver as well as intestinal wall is metro and tinidazole as well as emetic. Let's go to the next slide. How to manage the asymptomatic cyst passer. This person has cysts in the intestinal lumen, and we want a drug which will be luminal amebicide. Have a look at the chart. Luminal amebicide will kill the cyst. What are the options available? Number 1, dialloxanate furoate, 500 milligrams 3 times a day for 10 days. You have another option, that's diiodohydroxyquine or iodoquinol, 650 milligrams 3 times a day for 3 weeks. Or you can think of using paromomycin, 10 milligrams per kilogram body weight 3 times a day for 7 days. Or you can think of using tetracyclines. So asymptomatic cyst passers, dialloxanate or iodoquinol or paromomycin or tetracycline. We go to the next slide. The luminal amebicides which eradicate cyst in the lumen include dialloxanate furoate. This is directly cidal agent. It's quite safer and it can produce some gastrointestinal disturbances as indicated here. It doesn't have any tissue action obviously, so we call it a luminal amebicide. And it's contraindicated in pregnancy, contraindicated in the children, less than 2 years of age. The second drug which is available is a newer drug, is called nitazoxanide, and that's a prodrug, gets converted into tizoxanide. This is used in the dose 500 milligrams 2 times a day for 3 days, and this drug is able to inhibit the pyruvate ferredoxin oxidoreductase, that's PFOR, is a similar kind of mechanism of action as that of metronidazole. This drug also inhibits trichomonas, H. pylori, roundworms, and tapeworms, especially Hymenolipis nana. So that's about diloxanide and nitazoxanide. Amongst the other luminal amebicides, you have iodoquinol or diiodohydroxyquine, used in the dose 650 milligrams 3 times a day for 3 weeks. This is useful not only against amoeba, it's useful against giardia, and is also useful against trichomonas. This drug produces certain typical adverse effect, is the gastrointestinal intolerance, nausea, vomiting, diarrhea, and green stools and itching. Plus, it produces iodine intolerance and produces iodism in the form of mucositis, and can produce thyroid dysfunction in the form of goiter. It can also produce optic neuritis. So that's diiodohydroxyquine. There was another derivative or related drug was called quinidochlor or iodochlorohydroxyquine. This drug is now banned. This is not used. What's the reason why the drug was banned? Because this drug produced subacute myelooptic neuropathy and blindness many years ago in Japan, and it was a disaster, and after this quinidochlor is banned. But you could be asked sometimes on your multiple choice question about this particular illness, subacute myelooptic neuropathy and blindness, an important adverse effect for quinidochlor. Next, you have paromomycin and tetracyclines, which can have a direct effect on the amoeba. Plus, they will decrease the bacterial flora, and this leads to killing of the amoeba or destruction of the amoeba. Especially older tetracyclines are useful because older tetracyclines are incompletely absorbed and they remain in the intestine. So poor oral absorption is in a way helpful in the action of tetracyclines. Next, we go on to discuss intestinal wall amebiasis. Intestinal wall amebiasis. So it's quite clear. Metronidazole 800 milligrams 3 times a day for 5 to 10 days, or you can give it intravenous as indicated here. Have a look at the slide. Or tinidazole could be used 600 milligrams 2 times a day for 5 to 10 days, or just 2 grams every day for 3 days. Or you have an option of using secnidazole 2 grams in a single dose. 2 grams in a single dose. This is going to kill the tissue forms in the intestinal wall. So you've already killed the intestinal wall amoeba. Now you have to follow this whole treatment by using diloxanate furoate for 10 days or tetracycline for 10 days. I hope you understand the reason, because when the amoeba went to the intestinal wall, it's very likely that you have the cysts in the intestine and you must eradicate them. Then that will be the complete management of this disease. Diloxanate tetracycline will have only luminal action and will eliminate the luminal infestation to eradicate the carrier state. And emetin is reserved for severe acute cases. Use metronidazole, tinidazole, secnidazole, and if the disease is severe, you can think of using emetin. Next slide, we progress to discuss hepatic amoebiasis or amebic hepatitis or liver abscess. And I hope you remember, metronidazole, tinidazole is the drug of choice. Metro for 10 days or tinidazole for 5 days, because it acts on the liver as well as the intestinal wall. Plus you can add diloxanate once again to kill the luminal forms, and it's going to eradicate the carrier stage. Plus you can use chloroquine because it is specific for liver, and you can use it in the dose of 500 milligrams 2 times a day for first 2 days, and then 500 milligrams every day for next 3 weeks. So metro for the liver amoeba plus diloxanate to eradicate the luminal forms, and chloroquine to take care of any remaining amoeba in the liver, because chloroquine is very specific for the amoeba in the liver. Emetin is again added if the condition is very acute or if the condition is very severe. So that's how we have three different strategies, one for asymptomatic cyst passes, second one for intestinal wall amebiasis, and the third one for hepatic amoebiasis. So that was a brief discussion of imidazoles and the brief discussion of management of amebiasis. I think it's the right place to speak about emetine or dihydroemetine, which I said is reserved for severe and acute cases in intestinal wall amebiasis as well as in hepatic amoebiasis, that's the affection of liver, because this drug can kill trophocytes. So your drug of choice is metro or tinidazole, but if the case is very acute and if it's very severe condition, you can think of using emetine or dihydroemetine. Please mind well, it has no effect on the luminal cyst, and the route of administration, have a look on the slide, is subcutaneous or intramuscular. That's 60 to 100 milligrams every day, which becomes about 1 milligram per kilogram body weight. And mind well, to be given only for 3 to 5 days. What's the reason? Because the drug is toxic. It can produce gastrointestinal intolerance, weakness and muscle stiffness, but more important is the tachycardia, the ECG changes, the cardiac arrhythmia, the myocarditis, hypertension and heart failure. So it's got so many cardiac adverse effects, and this is why we cannot continue emetine or dihydroemetine for more than 3 to 5 days. So please remember, for severe acute cases, emetine or dihydroemetine just for 3 to 5 days, and it will be obviously contraindicated if the patient suffers from a major cardiac illness or major renal illness, and also in the pregnant women. So that was emetine or dihydroemetine. We go to the next slide and let's discuss chloroquine in all. Chloroquine is useful for extraintestinal amebiasis, and that also is useful only for liver, only for hepatic amoebiasis, and there's no effect on amoeba in the intestinal wall. It's used in this condition in the dose of 500 milligrams 2 times a day for first 2 days, and then 500 milligrams just once a day for next 21 days. It takes a long time and it produces its effect on the amoeba present in the liver. The next slide is showing you all the uses of chloroquine, and it will be worthwhile to revise chloroquine uses. Number 1 is acute attack of malaria, especially vivax, which might be still sensitive to chloroquine, and in this condition you can use chloroquine as a drug which is going to produce the effect on the RBC stage. Next, you can think of using it in extraintestinal amebiasis or amoebic liver abscess, which we just now mentioned. The third use is used as anti-inflammatory drug in Leber reactions, in systemic lupus erythematosus. It's used as an immune modulator or a disease-modifying anti-rheumatic drug in so many illnesses. This includes the lupus erythematosus, includes rheumatoid arthritis and infectious mononucleosis. So I hope you remember chloroquine is an important DMARD, disease-modifying anti-rheumatic drug. So these are some other uses of chloroquine. Next, you can use it for Chinese liver fluke infestation. It's useful for fish tapeworm infestation. It's also useful for giardiasis. So under this heading, we discussed so many drugs, and we came to know about emetine, dihydroemetine. We also discussed about the chloroquine and the other uses of chloroquine. I think this module was good. You had some information about chloroquine, you had information about the imidazoles, and you also learned about various types of amebiasis. Thank you very much and best of luck.